Welcome back to our continuing journey through step 1 of diagnosing transthyretin cardiac amyloidosis. In this lesson, we shift focus from red flags and systemic clues to the core of cardiological evaluation, electrocardiography, echocardiography, and laboratory investigations. We'll explore the classic ECG patterns that should raise suspicion for amyloidosis, like low QRS voltage and pseudo-infarct patterns. But we'll also discuss why a normal ECG doesn't rule out the disease. Then we'll take a detailed look at echocardiographic features, especially strain imaging patterns like apical sparing, that can differentiate ATTR-CM from hypertensive or hypertrophic cardiomyopathies. And finally, we'll cover key laboratory tests, including serum and urine immunofixation and light chain assays that help us exclude AL amyloidosis, an essential step before proceeding with nuclear imaging. These tools form the diagnostic bedrock for ATTR-CM. So in this module, we'll walk through how to interpret them, what patterns matter, and how to integrate clinical, imaging, and lab data to support a confident diagnosis. Let's begin with the electrocardiogram, one of the most accessible and frequently performed cardiac tests. In patients with transthyretin cardiac amyloidosis, the ECG often reveals a set of subtle yet telling abnormalities. Among the most characteristic features is low QRS voltage in the limb leads, defined as amplitudes of 5 mm or less. This occurs despite the presence of markedly thickened ventricular walls seen on echocardiography. And it's precisely this discordance between voltage and wall thickness that should raise clinical suspicion for amyloid infiltration. Another red flag is the presence of pseudo-infarct patterns, Q waves in leads that mimic prior myocardial infarction, but without corresponding evidence on imaging or history. Conduction abnormalities are also common, including atrioventricular blocks, bundle branch blocks, and prolonged PR intervals. Over time, these may progress, necessitating pacemaker implantation in a significant number of patients. And finally, atrial arrhythmias, particularly atrial fibrillation, are frequently encountered. In many cases, atrial fibrillation is one of the earliest cardiac manifestations of ATTR-CM, particularly in older adults. Together, these electrocardiographic clues, low voltage, infarct-like patterns, conduction delays, and atrial fibrillation, form a distinctive electrical signature that, while not pathognomonic, should prompt further investigation for cardiac amyloidosis. Figure 1 on screen illustrates this electrical phenotype with examples of atrial fibrillation, conduction disease, and ventricular arrhythmias, all typical in cardiac amyloidosis. One of the most telling ECG findings in cardiac amyloidosis, particularly ATTR-CM, is low QRS voltage. This is defined as a QRS amplitude of less than 0.5 millivolts in the limb leads and less than 1.0 millivolt in the precordial leads. While this feature is common in AL amyloidosis, it also appears in ATTR-CM, often in the context of disproportionate left ventricular hypertrophy. And that's what makes this finding so diagnostically powerful, what we call a voltage-to-mass mismatch. In most hypertrophic conditions, like hypertrophic cardiomyopathy, thickened ventricular walls generate high QRS voltages. But in ATTR-CM, you may see normal or increased wall thickness on imaging, yet paradoxically low voltage on ECG. This mismatch is not due to true hypertrophy, but rather to amyloid infiltration, which insulates the myocardium and disrupts electrical conduction. The result? The heart looks hypertrophied on echo, but the electrical signals are dampened on ECG. This voltage-to-mass discrepancy is considered a hallmark of cardiac amyloidosis and should always prompt further investigation, especially in elderly patients presenting with heart failure and thickened walls. As shown in Figure 2, the QRS voltages are dramatically reduced across all limb leads, with small R waves and reduced S wave depth. This type of ECG pattern should immediately raise suspicion for infiltrative cardiomyopathy, and ATTR-CM should be high on the differential. Another electrocardiographic red flag in transthyretin cardiac amyloidosis is the pseudo-infarct pattern. This appears as QS complexes in the anterior leads, V1 through V3, or as pathologic Q waves in the inferior leads, which can easily be mistaken for signs of a prior myocardial infarction. But here's the catch. These patients often have no history of coronary artery disease, and coronary angiography usually reveals no obstructive lesions. So what's really going on? These pseudo-infarct patterns are caused by subendocardial amyloid deposition, which disrupts normal myocardial conduction and repolarization, but without the ischemic injury that typically causes Q waves. Troponin levels in these patients are often normal or only mildly elevated, helping to differentiate ATTR-CM from an actual infarction. In Figure 3, we see a classic example, a patient with confirmed wild-type ATTR showing a pseudo-infarction pattern in the anterior leads. Interestingly, despite significant concentric left ventricular hypertrophy on echocardiography, there is no low QRS voltage, which further complicates the diagnosis. These patterns highlight the importance of correlating ECG findings with imaging and clinical context, because what looks like a heart attack may actually be cardiac amyloidosis. Let's have a look at this figure. This electrocardiogram highlights two classic findings associated with cardiac amyloidosis. First, focus on the red box. This area shows low-voltage QRS complexes in the limb leads. Despite the presence of increased left ventricular wall thickness on imaging, which would typically correlate with higher voltages, we see the opposite here. This voltage-structure mismatch is a hallmark red flag for infiltrative cardiomyopathy. Now shift your attention to the blue box. This highlights a pseudo-infarct pattern characterized by deep Q waves in the precordial leads. This can easily be mistaken for prior myocardial infarction. However, in this context, there is no clinical history of coronary disease, and imaging would not show regional wall motion abnormalities. These two features, low voltage in limb leads and pseudo-infarct patterns, are highly suggestive of cardiac amyloidosis and should prompt further investigation. Now let's turn to one of the most frequent arrhythmias seen in transthyretin cardiac amyloidosis, atrial fibrillation, or AF. Studies show that more than 50% of patients with wild-type ATTR develop AF, often in the absence of traditional triggers like hypertension or elevated left atrial pressure. That's because the atrial tissue itself becomes infiltrated by amyloid, leading to electrical inhomogeneity. In simple terms, the normal electrical signals in the atria become fragmented, which promotes fibrillatory conduction. So what do we see on the ECG? First, irregular RR intervals with absent P waves, which is the hallmark of AF. Second, even outside of active fibrillation, patients may show prolonged P wave durations and abnormal morphologies, indicating delayed interatrial conduction. And third, low atrial voltages are commonly seen, suggesting that the atrial myocardium has undergone significant amyloid-induced myopathy. What does this mean for management? Well, the risk of stroke and thromboembolism is markedly elevated in ATTR-CM, so anticoagulation is often recommended, even in patients with a low CHA2DS2 VASC score. In the case shown in Figure 4, a 54-year-old man with variant ATTR presents with a left bundle branch block and anterior pseudonecrosis. We see deep Q waves in leads V1 through V4, each measuring over 1 millivolt. Importantly, this patient has no history of ischemic heart disease, and echocardiography shows no wall motion abnormalities, again illustrating how amyloid deposition can mimic infarction on ECG. In another case shown in Figure 5, a male patient with a wild-type ATTR-CM and severe cardiac involvement. We see 12-lead ECG showing atrial fibrillation, pseudo-infarction pattern in V1-V2, red asterisks, LQRSV and STT abnormalities in lateral leads, strain pattern, red arrows. These atrial findings are crucial clues in diagnosing a ATTR-CM and should always prompt further investigation, especially when they occur without conventional risk factors. Next, let's discuss a hallmark complication of transthyretin cardiac amyloidosis, conduction system abnormalities. In patients with ATTR-CM, especially the wild-type form, conduction disease is common and often progressive. That's because amyloid deposits infiltrate the electrical pathways of the heart, leading to delayed or blocked signal transmission. Here are the most frequent conduction disturbances. First-degree AV block, where the PR interval exceeds 200 milliseconds, signaling slowed AV nodal conduction. Mobitz type 1 and type 2 second-degree AV block, showing intermittent dropped beats. Complete AV block, which frequently necessitates permanent pacemaker placement. And left bundle branch block, commonly seen due to amyloid affecting the interventricular conduction fibers. Now, what makes this particularly important is that patients with ATTR-CM have significantly higher pacemaker implantation rates compared to those with other cardiomyopathies. In fact, some patients require pacing even before the onset of overt heart failure, highlighting the value of early rhythm surveillance in this population. In Figure 6, we see the ECG of a patient with confirmed wild-type ATTR. It shows two classic features: atrial fibrillation and a pseudo-infarct pattern in the inferior leads, Q waves that mimic infarction despite no obstructive coronary disease. In Figure 7, we see the ECG of a male patient with a wild-type ATTR-CM. ECG recording showing atrial fibrillation, right bundle branch block, red asterisk, left anterior fascicular block, and STT abnormalities in inferolateral leads. So, for any patient presenting with new conduction abnormalities, especially when accompanied by unexplained LV wall thickening, a TTR-CM should be on your differential. Early recognition can guide timely pacing interventions and improve clinical outcomes. When interpreting ECG findings in patients with heart failure, it's essential to distinguish transthyretin cardiac amyloidosis from other conditions that may present with similar symptoms or imaging features. The differential diagnosis includes AL amyloidosis, hypertensive heart disease, and hypertrophic cardiomyopathy, HCM, but key ECG features can help point us in the right direction. Let's go through the most important distinctions. First, low QRS voltage. In a TTR-CM, this is common, particularly when it appears out of proportion to the thickened ventricular walls on imaging. This voltage-to-mass mismatch is a hallmark clue. In AL amyloidosis, low voltage is almost always present due to more aggressive infiltration. By contrast, HCM typically shows increased voltage, reflecting true myocyte hypertrophy. Second, pseudo-infarct patterns. In ATTR-CM, you'll often see QS complexes in leads V1 through V3, or pathologic Q waves in the inferior leads, mimicking a prior MI despite normal coronaries. These patterns are frequent in AL amyloidosis as well, but rare in HCM. Third, conduction abnormalities. Atrioventricular block and bundle branch block are highly prevalent in a TTR-CM. They do occur in AL amyloidosis, but much less frequently. In HCM, they are rare. And finally, atrial fibrillation. This rhythm is very common in ATTR-CM, affecting over half of patients with the wild-type form. AF is also seen in AL amyloidosis, but it's far less frequent in HCM. As a rule of thumb, in older patients with heart failure and preserved ejection fraction, when you see low QRS voltage, pseudo-infarct patterns, and conduction disease all on the same ECG, you should have a high index of suspicion for ATTR-CM. Let's now look at how artificial intelligence is reshaping the ECG landscape, especially in the early diagnosis of a TTR cardiac amyloidosis. Thanks to deep learning and neural network technologies, AI-based ECG interpretation has shown remarkable promise in identifying amyloidosis-related electrical abnormalities, even in patients without any symptoms. In a landmark study, ATTR and colleagues, 2019, trained AI models on massive ECG datasets and found that these systems could accurately detect subtle signs of a TTR-CM that might otherwise go unnoticed. So how does AI help? First, deep learning algorithms analyze thousands of ECG variables simultaneously. These models can distinguish a TTR-CM from other types of cardiomyopathy by recognizing the unique electrical signature caused by amyloid infiltration. Second, prediction models can flag high-risk individuals even before clinical symptoms begin, enabling proactive screening and timely diagnosis. Third, AI improves the recognition of low QRS voltage, fragmented QRS complexes, and first-degree AV block, findings commonly missed by conventional readings. So what are the clinical applications of this technology? One important area is automated screening. AI-augmented ECG tools can be integrated into electronic health records to continuously monitor for patterns indicative of ATTR-CM. When detected, the system can flag those patients for further cardiac imaging or genetic testing. Another key role is in the early identification of ATTR-CM in asymptomatic or at-risk populations. This capability is particularly valuable for patients with subtle red flags, like unexplained heart failure with preserved ejection fraction. Additionally, AI-driven ECG models can help stratify patients by their likelihood of needing a pacemaker. Given that conduction system disease is common in ATTR-CM, this tool can be instrumental in determining which patients may require early device implantation. Finally, the prognostic value of AI is significant. It allows clinicians to monitor disease progression and to intervene with disease-modifying therapies at the optimal time. In summary, by leveraging advanced neural network analysis, AI-enhanced ECG interpretation offers a powerful tool for screening, diagnosis, and disease management in transthyretin cardiac amyloidosis. It marks a new era in precision cardiology, bringing us closer to preclinical detection and more personalized care. In the next lesson, we will explore the cornerstone imaging modality in the evaluation of transthyretin cardiac amyloidosis, echocardiography.